Okay, we'll get started. Hello, greetings. Welcome everyone to almost the last session of the day, at least this last presentation session before the posters. My name is Vincent Wong. I am with USAID OHA in Washington, and I am a branch chief for behavioral and structural interventions. So you guys are all in the social and behavior change, moving from theory of change to lessons learned. We have a great panel today who I'll introduce shortly. Okay, good. And I'll just have a couple of introductory slides. And I want to give a big thanks to my colleague, Dr. Suzanne Leclerc-Madlala, who helped organize this session. She wasn't able to make it here, but I'm presenting in her stead. So just a couple of quotes to start off here. The first one from our ambassador: behavioral science and social science is a cornerstone of the HIV response. This is from a speech he gave at CROI. And then from our Administrator Power, when we apply behavioral insights, we are much better equipped to make a difference, which came from a speech she gave on the importance of social and behavioral science in our programs. So this is going to be my last slide, I think. This is really just from the PEPFAR guidance that came out a few months ago. There's a new strategy that's on its way out, but you'll notice the first element under Pillar 5, behavioral science as a core component of PEPFAR programming. And that's going to come to the fore in a lot of different areas under health equity, looking at partnerships, digital health, health workforce. It's going to begin playing a bigger and bigger role as we aim to reach our epidemic control goals. So with that, I'll say that we are working with SGAC and others in PEPFAR to try to define what we mean when we say behavioral science. For us at USAID, it's an encompassing term, and we use SBC, social and behavior change, and behavioral science interchangeably. So you'll see those terms both used synonymously. But within that, in the umbrella, we encompass a lot of other interventions. We talk about behavioral economics, human-centered design, social and behavior change communication, social marketing. All of these pieces are within the toolbox of behavioral science, and we like to see how we can apply those to our programs to amplify our outcomes. So we'll be hearing from colleagues today on a number of really interesting approaches, and starting with Lola Molete here to my left, who will be presenting on Tebelo Pere. We saw a great prep session in the other room just before this. This will be looking at, in greater depth, the cookie jar approach and the use of social media to increase demand in adolescent girls and young women. So with that, and I'll introduce each person as we go along. But with that, I'll turn it over to Lola.
Thank you so much, Vincent. Hello, everybody. I'm very honored to be here this afternoon. So before you is Tepiso Lulama Molete, as they mentioned, the Content Marketing Administrator of Develop Bill. So what is the cookie jar? The cookie jar is a safe space for young women between the ages of 15 to 24. This safe space supports young women to access quality and relevant information to their questions in regards to relationships and sexual health. This group also maintains high standards of confidentiality, and currently on the Facebook group, we have 1,586 members. So one might ask, why the name the cookie jar? So it's more figurative than literal, meaning that the issues that young women go through, they love bottling up these issues. So the jar represents the young women bottling up the issues, and the cookies represents the actual issues that we help them unpack, and we nibble on these issues. By nibbling, meaning that we find solutions for these young women to access these services. So a brief background, according to the Botswana statistics, The HIV incidence among the persons between the ages of 15 to 64 is estimated around 0.2, meaning that each year you have 2,200 new cases, right? And there's a high prevalence amongst young women with 9.4% as opposed to males with 4.3%, which is really concerning. So the cookie jar is under the project the Katelopele mo Botsogong. Katelopele mo Botsogong meaning walking together in health. It provides tailor-made integrated facility specific. It provides tailor-made specific gap-related HIV and AIDS treatment and care to support young women with HIV prevention services. So the Katelopele mo Botsogong project focuses mainly in 3 geographic locations, which is Gaborone, Kwening East, and Francistown. And one may ask, how was the cookie jar established? So the cookie jar was established in 2017, then by FHI 360. It was the custodian at the time under the project called Advanced Partners Communities 2.0. So for the cookie jar to be established, it was established through a focus group discussion, right? A situational analysis was done, and the preferred medium was Facebook group, since young women, most of them love accessing their phones through Facebook than any other platform. So in October 2021, Developele then became the custodian of the Cookie Jar Facebook group. So since the group was founded in 2017, we realized there's such a significant gap. We were unable to report, the referrals made from the group to young women accessing these facilities. And this is when we realized that, okay, actually, we need to actually put in place healthcare educators. The healthcare educators are also content managers of the Facebook group. And the healthcare educators are all placed in Gaborone, Malapula, and Francistown in the clinics that the Katelopele mo Botsogong project operates in. So as you may see, since Developele was the custodian of the cookie jar, we have seen an increase of 782 members in the group, and young women were referred for HIV testing, 256 of them, and 92 of them were referred for contraceptives, 157 of them were referred for Dreams Safe Space, and 27 of them for GBV services, and 209 were referred for PrEP. Now, here's a theory of change from the initial beginning of how the cookie jar came into being since 2017, right? The problem we had was that there's a high rate of HIV new infections each year amongst young women between the ages of 15 to 24. And we realized that the barriers was mainly young people love spaces where they are able to talk to, nurses without fear of judgment and to be treated in a cordial manner. And half of the time, it's not the case in facilities in our country. And the other barrier was that there's so much stigma around PrEP that it's normally taken by key populations and sex workers. So they refrain from taking PrEP because of this issue. And we also have what you call intergenerational relationships and multiple concurrent partners. So one of the interventions that we managed to come up with was collaborate with other stakeholders, which is the Ministry of Health as well as NAPA. And mocktail sessions, we realized in-person sessions actually help young women to be more comfortable in accessing services, unlike just always telling them about it either at school or just online, because they are more comfortable if they know the person. And sensitizing the community about PrEP as well. From time to time, we do community mobile outreaches where we teach the community about PrEP and the importance of it, as well as the condom use education. So the outputs that we have what you call AGYW corners. This is like literally a room where you have magazines and games where young women can just be comfortable before they can access any service they came for in the facility. As well as we maintain a constant supply of PrEP pills so that these young women do not default. And the outcomes of that is the increased knowledge about HIV prevention, which is PrEP and PAP, and the impact that it has. Gradually, it has decreased prevalence of HIV new infections amongst HYWs, and we're hoping to achieve an HIV-free generation. So this is just the flow of how the cookie jar was programmed. Through the focus group discussion, 12 content managers were recruited, and it was officially launched in September 2018. So the lessons we've learned is that social media is not enough to mitigate issues of HIV new infections amongst young women. So having more in-person sessions and peer-led programs can actually create demand in the uptake of these services offered by developing. And we realized that social media alone can become monotonous, mostly when you speak about health. So young people love what you call where you can meet up, have picnics, and you can sit around and talk about these topics. They find it more appealing, unlike just talking about it. And also, we realized that the closed Facebook group doesn't give you an option for anyone to send DMs. And normally, they identify us through the badges in the group who are labeled content managers. And we realized that maybe we should explore other platforms which are more intimate, like WhatsApp groups. In conclusion, being a content manager, really, from time to time, we really realized that, okay, learning how to speak health and also trying to explain it to a young person, it really takes a great skill of interpersonal communication skills. From time to time, they need to be trained. And as well as the strategies that are consistent with adherence, as well as having reminders, because young people are people that always live busy lives. So always reminding them that they have an appointment or a follow-up can really assist. And going forward, we're hoping to have a helpline where young women can always, call at any point in time that in need, especially with issues of gender-based violence. As you could see from the table, the numbers were quite low because there's no such a platform for them. Thank you so much.
Great. Thank you so much, Dr. Ms. Molete. So our next speaker is going to be zooming in, and we should be hearing from Ms. Charlotte Uzanaze, excuse me. And she is the MEL Director for OVC and Dreams Interventions at the Obaka Iju Project. Apologies. With the African Evangelical Enterprise in Rwanda. So we'll take a moment and hopefully we are just waiting for the Zoom to come up.
Yeah. So thank you so much. As I said, I'm presenting from Uganda, which gives a brief background of implementation in Ministry of Health in Rwanda introduced the program, especially to 10 years of people, especially the female sex workers and the MSM couples. But after some 2 years, consultation is paid for. The Ministry of Health revised the national guidelines for HIV to also include adult girls and young men, especially those who are at risk of acquiring HIV/AIDS. So in Rwanda, the HUI have a specific criteria for screening those who are on PrEP, especially those who have so many adults and girls who are very consistent and engaging in transactional sex, especially with the age between 18 and 24. And also have those who have sexual partners that are HIV positive and not suppressing. So those are some of the enrolling HUI on PrEP. Next. Slide. So as implementing the PrEP in Rwanda, especially under PEPFAR, USAID, it was based on recent 2021 that we introduced PrEP in Rwanda. among adolescent girls and young women. So we built resistance, of course, at the first implementation. And this is the theory of change that drives us in the implementation that I would like to share with you, and also share with you some lessons learned in implementing this theory of change. One is the demand creation. So the statement is that if peers provided with the right training and supported to give their peers within the safe space the trusted information, and also if we are engaged in the community where the parents and community leaders, healthcare workers are educated on PrEP as an HIV preventive approach and are engaged in the healthcare decision making. We also not forgetting the HOA themselves, whereby if we engage them to facilitate to access health services, get engaged in decision-making firms, and also get their input in program design, implementation, and empowered to educate others, then whereby we engage all these approaches in implementation of PrEP, then we will see that this will lead to an increase in PrEP uptake by HUI, and of course, we also reduce the HIV infection, or it will decrease. So this is our theory of change and the expected outcome through engaging or employing all these models that are presented before you. Next slide. Next slide. So this is our program approach as you are implementing dreams. Now, please go back.
Yeah, there's a delay. So yeah, that's the slide.
Thank you so much. So in the dreams program, we use safe space. This is the safe space for girls, female girls, grouped between 25 to 30, whereby they come together, especially those that have similar circumstances or life experiences, and share and learn together, learn the similar things, share together, and it's where they are safe. And it's close to their community, where we provide the comprehensive package according to their age bands or segments. The female sexual workers, the teen mothers, they all have their same groupings and are provided with comprehensive package according to the we use what we call layering services. And as you can see down, we have peer support groups, mentorship, which is very key, where mentors the similar age providing mentorship to these adolescent girls and young women. And as you can see on the other side, we have health facility, meeting partner. We strongly have the collaboration with health facility through establishment of MOUs or memorandum of understanding, whereby they will provide the services that which as an implementing partner cannot provide in the safe space. And this is where the active contra referrals and linkages are done between the community and the healthcare workers, and then the follow-up. So this is where health facility provides initiation, whereby the community IPs do provide education, especially, and also the health facility provide the screening in terms of the and also start the initiation. So on the ground level, you can see the joint mentoring supervision. This is whereby and the community implementing partner and health facility, we do the joint monitoring to see how the services are being adhered to in the community. Next slide. So the next slide is I would like to share with you the achievements as we employ the theory of change. As you can see from quarter 1 and quarter 2 of this fiscal year, 2022, The results were really not good because we had the targets around 600, and we still had low demand, low uptake of PrEP, and we had to revise changes really worked for us. And you can see there was a abrupt increase from Q2 and Q3. The shift was from 16% to almost 67% of achievements, and there is really a difference of 50%. You can ask what exactly did you do to make this shift? One was engaging HUI themselves, especially the PrEP clients, we call them PrEP champions, and asking them how else can we engage, how can we mobilize at least adolescent girls in the community, because they are already there, very many in the transaction sex. And then they said, okay, this is how we need to do. We need to give us some basic training so that we can also mobilize our colleagues. So that's how we used our peer, we call them peer PrEP champions, whereby they are those who will now go in and talk to their colleagues, their peers, and then bring them on board. And also another strategy that was used is to engage these peer PrEP champions and health facility. During the counseling, this was to avoid the fear of healthcare workers judging, the judging the HUI, especially those who are living in some community. So when they see their peers on board taking PrEP, they are very proud. They are sharing the benefits of PrEP, and then they are encouraged to also start the uptake. So that's the second strategy that was used in terms of to raise the number of those that were initiated PrEP. And another strategy was now to the messaging that was provided. These girls need an empowering message. Not really saying that you have to take PrEP unless if you don't do that you'll die. So there was a revision of the messaging that was provided to these adolescent girls who are at risk and who need to be initiated on PrEP. So those are some of the strategies, and especially also the joint meeting between healthcare workers and peer PrEP champions, that they could discuss how they should use the language, they should make their language when they are really counseling boys and girls and young women who are being initiated PrEP. So we see a change in terms of initiation because of the strategies that were raised. Next slide.
And you have 2 minutes remaining.
So very quickly, on actions, you have two levels of interventions. This is community level interventions and the health facility level interventions. First of all, of course, these are continuing activities, especially in the community whereby we have this Families Matter program introducing education among community that they have to get to be engaged in decisions of their daughters, and also engaging men. And this facility, especially in engaging, educating healthcare workers through AC materials and building interpersonal communication skills and healthcare facility. Next. Was the last slide. So the lessons learned is that engaging informative and appealing PrEP messages. So peer-led program, higher demand creation and uptake. These peer educators taking PrEP potentially very beneficial and supporting uptake. Also creating an enabling environment for service delivery, ensure continuous follow-up and support of this. MBUs with these facilities have empowered peer PrEP champions to work effectively in a good environment. Thank you so much.
Thank you very much. Thank you, Mrs. Sanaze. Wonderful. Okay. Our final panelist for today is Dr. Jose Carlos Quinones, a medical doctor and surgeon with more than 12 years' experience with health projects in Central America, the Caribbean, and Asia. He's worked in areas of sexual and reproductive health, maternal and child care, Zika and HIV, among others, and is currently the regional manager of strategic alliances and special projects to PASMO, the Pan-American Social Marketing Organization. So welcome.
Can I have a... Thank you. Buenas tardes. Good evening. It's nice to be here. Good morning around other parts of the world. I will start Introducing ourselves, as our colleague mentioned, we are PASMO, the Pan American Social Marketing Organization. We are based in Central America with our regional office in Guatemala, but we have branches and offices in Guatemala, El Salvador, Nicaragua, and Panama. We have been working for a long time in FP, sexual and reproductive health, and other areas, and recently in comprehensive health for transgender women, for example. And we are part of the global network of PSI. And currently, we are implementing in Central America this project, Prevention Services Against HIV, which is working in the two initial pillars of the cascade. And what is giving is preventive services to high-risk individuals, and men who have sex with men, transgender women, and other at-risk individuals, because the epidemic in Central America is concentrated in those groups. That's why the project is focused on that. Talking about the HIV self-testing itself, which is what brings us here, what we did in 2018 is checking what the regulations and policies were in or what the status were in the region. And what we found is that none of the countries had political regulation, even registration for STs. In 2018, so we carried out a market estimation for knowing a little bit more what would be the gap to close, because there was a little bit of fear from other actors to that the self-testing could compete with the regular tests. So we have to show with evidence that that wouldn't happen. Then we carried out a client acceptance, that it was a qualitative study for to know what would be the acceptance of the tests, even blood or an oral test. And with those results, we validated and created the Prisma strategy, which is what I'm talking today. And we launched the self-testing services in Guatemala and El Salvador in 2021. Another study we carried out was an online study with MSM to understanding a little bit more barriers and motivations about the test. What we found was that the main barriers for testing on HIV was that 72% feared lack of confidentiality when they were testing. 63% says that it's annoying to get back for results in those cases that they have to. And 50% do not feel comfortable with the staff that perform tests. So these were needed solutions. The good part was that we found that 78% intended to be tested, and 94% were able or would self-test if the HIV self-testing would be available. With that in mind, we have developed this theory of change, which is that if the availability of new forms of HIV diagnosis increases, more people will know their diagnosis. Then the number of people who know their HIV status will increase. And increasing the number of people who will know if they are positive will get more into treatment, or if they know that they are negative, they will get more into preventive measures. For that, we develop these key interventions: generation of local evidence, development of national regulations, development of the Prisma program, awareness, information, and demand generation campaigns, delivery of the service itself, and of course, the follow-up of positive cases for confirmation and linking them into care. Prisma is the strategy we are using, and it's called Prisma and is validated as Prisma because we didn't want to link the name with HIV tests itself, because it would be a problem. So we are keeping the confidentiality and privacy of clients using this, because all the materials, the test materials for what to do if the result is positive, of PrEP information in case they want to get into PrEP is included into the kit, condoms as well, and another information that could be available by the moment, depending on the programs available. So this is an hybrid model based on technology and non-supervised self-administration with cyber educators providing information. And we have a cadre of cyber educators trained on giving information using mainly social media. Cyber educators provide this follow-up using social media in case that they find a positive case. This is one of our cyber educators, working on the Prisma strategy here. They create some information as well, using TikTok, Instagram, and other social media to inform the people, to educate the potential clients, and of course to use these tools or media for delivering the service. The service delivery itself use filters for knowing if they are at risk, and if they are very good clients for this kind of service, they register the client using USCIs, then deliver the method using 3 different methodologies of delivery. For example, the client can pick up the test in our offices, or can go to other NGOs with which we have some relations and stock there, and they can receive the test in their homes or at their office, for example, in a door-to-door delivery model, which is paid by the client. And of course, the follow-up, which is totally necessary. Here we have some results. And here we can see basically the trend that is going up in general, but something that is very important to understand. One of our challenges was the stock out we faced in El Salvador during 3 months, but it was because the demand was really low. And now that we are increasing the demand, having more negotiations with other providers, this kind of problem is solved. So in this other part, we can see that mainly our population is young, from 20 to 34 years, but it's important to mention that a very nice number of adolescents are getting the test, especially in our countries where adolescents cannot perform a regular test without the parents, for example, or a family member. Grindr, WhatsApp, and Facebook are 50% of the sources of our contacts, and when and the service is being delivered mainly in Guatemala by delivery service, and the delivery service is paid by the client. So this is saying that the client is empowering himself with taking decisions on health. This is in terms of social behavior change, and these are some of the bubbles that we identified, and we are working with the self-test in terms of availability, attractive brand, the quality of the brand, of course, and the service is very high quality, being honest. And of course, working on the social norms to destigmatize the testing. In terms of ability, we're working with knowledge, self-efficacy, and motivation. We are taking into account the intention of the client, product expectation, locus of control, and the willingness to pay for some kind of services that they have. Closing the gaps, it is important to notice that youth and adolescents access is being increased with this strategy. Online approaches are really effective. The Prisma is 100% confidential, as you saw. Testing and confirmation and linkage to care is really high. More than 80% of linkage to services is what we are finding with the self-testing strategy. The variety of brands and tests is ensuring us the stock. The variety and the use of the field and restricted method, for example, in El Salvador, when other kind of providers that are not certified cannot provide or perform tests, is something that is facilitating us to do these tests. Some key challenges and lessons learned during this implementation is the lack of guidelines was something really, really hard to see and to work. Working closely with the government, especially, or obviously the ministers of health, for developing these guidelines was one of the very good strategies we have. And authorities are not totally convinced with the implementation of HIV self-testing services, but sharing information about the market size of HIV testing and the advantages of self-test has to be included in all this process to make kind of lobby with these authorities. And finally, the supply chain, as I mentioned, is not efficient now that the demand is low, but we are step by step increasing this with more providers, with more brands, and even the prices are getting lower time by time, every time that we are making new negotiations with other providers. So developing tools for better estimations as well, and place purchase orders with the manufacturer in advance, obviously with all the problems with the chips and so on that is ensuring us the supply. Thank you so much.
Thank you so much, Dr. Paul. Sorry, this one. Okay. So thank you again to our panelists. Maybe another round of applause for them. They're fantastic. Lots of different aspects of our communications programming around our SBC programming tied to a lot of the interventions that we're looking to increase reach, to increase access. We've got 9 minutes and 45 seconds for questions. I don't know, is there a microphone to go around somewhere? Or shall we just call, if folks, I don't know if we're online. Hold on. Hello? Okay, where was that hand?
Very nice presentations. Well done to the teams. Good efforts there. My question to the last presenter, specifically on the linkage for those that test positive, we need to hear more in terms of how is it done. Is it them who take themselves to the facility? Do they call you to tell you about the results? So what happens? Or is it part of the cyber education? Then lastly is about where do you get these commodities from? Do you purchase them? In our country, we are short of these commodities to an extent where I don't know, the supply is low. So how do you get these commodities?
Okay, first one. I will answer the last question first. The project is paying for the commodities. Only the delivery is covered by the user. And in terms of linkage, first of all, in our countries, the self-test is not a confirmatory or an official test for saying that way. It's a screening test. So what we are doing is giving close follow-up to our clients, and all of them, most of them are sharing their results with the cyber educator because they can create a kind of link of confidence with the cyber educator. And he said, "Oh, look, this is my result," and blah blah blah. Even though if and they have written information about what to do in case of a positive result, they are sharing the result with the cyber educator, and the cyber educator send the client to a laboratory, a private laboratory, to make the confirmation. And if that in the case it is confirmed, so we have a person in charge of giving an accompaniment to the linkage to the treatment to those clients that are confirmed as positive. That's the way it works. I hope I answer your questions.
Thank you, everyone, for those great presentations. I really wanted to follow up on the self-testing piece. What was your yield like? And the same question, what was your yield like? Was it working better than when you use, for example, a peer-to-peer approach, like with your peer educators, peer navigators? That's question one. Question two, if you had a model before for testing where you were using, for example, peers, what were the challenges in acceptability of self-testing as a model, as opposed to or in tandem with the other models for testing that you have in your organization?
Great questions. Thank you very much. First of all, the yield is 3%, but for you to know, our strategy with self-testing is not really as focused as with the normal test, because what we are doing is trying to get more access to the client in terms of, they know the test, and it is like the first step that they can take for being tested. That's the thing. So the yield is not a kind of interest or highlight for us right now. Yeah, this is one. And talking about peers, for example, what we see with self-testing is, yes, receiving information from a peer is so much better. First, second, self-testing is one of the ways that our clients are getting tested, because this is a kind of branch that never will go to the private sector because they don't want to be identified. The other is that they never would go to an NGO clinic, for example, or laboratory because they don't want to be identified as gay people, because our project is focused on them. And the third one is that they would never go to a public facility because of all the barriers that they have. So we are covering these people who really are forgotten, and even if they have the possibility to pay for the services, because they are not really poor. We are working with middle class basically, but these are very forgotten by all the institutions because really they don't want to go to a gay clinic, they don't want to go to a government facility for so many reasons. So this is the group we are covering with this strategy mainly.
Thank you. Another hand.
Thank you so much for the 3 presentations. Very informative. I really enjoyed all of them. My question goes to Charlotte. I think she's joining online from Rwanda. I'm very much interested in knowing how I've seen that you've used multiple strategies to retain girls or to enroll girls on PrEP. And of course, you acknowledge the use of peers and the safe spaces in improving PrEP uptake, which is really impressive. But I also noted as one of your community strategies as integrating PrEP education for caregivers during the FMP sessions. And I wonder how much of that has contributed to your PrEP initiation, because I know from where I come from, much of PrEP initiation or continuation is determined by, social demographics of the URW. I mean, who they live with and their parents or caregivers' acceptance of PrEP and information. So I don't know if you have or can relate how much of your PrEP initiations or continuation are associated with, the parents having been given the PrEP education and etc. Thank you so much.
Thank you so much. This is a good question, and the reason why we adopted this strategy of including education for the caregivers is because when we're looking at the reasons for not initiating on PrEP, because the fact that we have referred so many girls to this facility, and we could see very few getting initiation. Most of the reasons, the 70% of the reasons, the girls were saying we are fearing our parents. And also the parents, because they didn't know a lot on sexual education, and you know that in the FMP we have this sexual education, but little is said on PrEP. So the fact that we introduced this education PrEP in the parents, now we started seeing a good number of girls now being confident that at least we have the back of our parents, of our guardians who are supporting us in getting this initiation. And this, like for instance, in terms of keeping our pills in safe place. So whenever they could take the pills, they didn't know where they could keep them in the house. The house would be too small. The kids will look at the pills. The parents will look at the pills. So now that the parents were.
But I think we got most of your answers, so thank you for that. And I saw one more hand here, and we've got another minute or so.
Thank you very much for your presentations. I wanted to ask the first speaker if you were doing the cookie jar only in urban area, because I'm just thinking, I don't know, Botswana's smartphone ownership amongst youth. And second question is, were there linkage to services? Otherwise, the value of them, speaking and being in that group, what would it be? Was there linkage to services? Thank you.
Thank you for your question. To be quite honest, when the group started off, we realized that the HIV high prevalence was mainly among young women, not forgetting also young women that don't have social media. We wanted to actually be able to reach because I feel like the young women between that age, they're unreachable, more so that, especially the ones on TikTok and Instagram, the ones that portray a lifestyle that they, at home, they're a totally different person as opposed to who they are when they meet other people. So these are the people that we realize that, okay, they are more prone to, behaviors that literally make them promiscuous, right? So obviously through the linkage, we can only be able to refer these young women if these young women actually reach out to us via our DM. And that's how we're able to reach out to them. Others actually just come to the facility. They don't tell us. But once they get to the facility, this is where they meet the healthcare educators, and they have a feedback form where they ask them, how did you find out about us? And that's how we can also report the referrals made from the group as well. And for those that do not have social media, this is where our Khatelo Pele mo Botsogong project, where it's based in the geographical locations as aforementioned, we do community outreach mobilizations. So this is how we can reach those that are not online. Thank you. I hope I answered your question. Okay.
Well, you can speak after. Thanks to everybody for coming to this last session. Thanks to the panelists, fantastic, and have a great rest of your conference.